Hello and good morning. My name is Dr. Philip Rajan, and I would like to welcome all of you all to the UiTM First International Online Vestibular Conference. Before I start, I would like to thank the organizing committee, Professor Masani and Dr. Intan for this invitation and for putting together this excellent program on vertigo and vestibular medicine. It's a comprehensive 2-day program, and there's a excellent faculty of teachers and trainers who will guide you all through every aspect of management in vestibular diseases. So what I'm going to do is to give you all an overview of vestibular disorders and clinical assessment of vestibular patients. Many of these things that I will talk to you about will be mentioned by other speakers. And in fact, some of these things will be even mentioned in greater detail by other speakers. But sometimes vestibular medicine is sort of a fuzzy kind of feel. And I think the more we mention these things, it is better for you to understand the concepts and to be able to apply it in clinical practice. So bear with us if there's a lot of repetitions, but I think it's good because the more and more these concepts are repeated, it becomes ingrained into us and we are able to apply it in our clinical practice. So what I'm going to do in this session is basically a combination of the two sessions that I've been given. I'm going to give you all a broad overview of what vestibular disorders are and what are the clinical examination steps that we do to try and determine the pathology or the site of the lesion. Okay, so as I mentioned, we want to first of all identify whether a patient who comes to us is actually suffering from a vestibular lesion. And vestibular lesions can be divided into peripheral or central. And one of the key features to help us identify whether it's a peripheral or central lesion is the presence of nystagmus and the type of nystagmus. And I will go into more detail about this later. And of course, we want to identify exactly where the lesion is with our clinical examination. And of course, we augment this with certain diagnostic tools. The later aspect on therapy I will talk about in my final lecture. And many of these things will be elaborated in further detail by other speakers. So just to recap what the previous speaker, Prof. Rostan, has mentioned about physiology. Okay, so balance is a complex process and it's mediated basically by three organs, the ear being the most important component, and that's the vestibular component. And of course, our vision and proprioception. So it is a combination of these three inputs which help us regulate our balance. Okay. So when we talk about the vestibular reflexes involved in balance, there are two main reflexes, and these are the vestibular ocular reflex and the vestibular spinal reflex. So the vestibular ocular reflex is what helps us to keep our eyes focused on a certain object when the body is in motion. And the vestibular spinal reflex helps us to maintain our posture. So whenever we walk, when we move, we do not fall because of this fine tuning of these vestibular spinal reflexes, which keeps all our muscles in our body in proper sort of contraction or relaxation so that we do not fall. So these two reflexes are very, very important. And in our clinical assessment, we are actually assessing the integrity of the reflex pathways of these two important reflexes, which help us maintain balance. Why do we get vertigo? Very simply, from these reflexes, these various reflexes, inputs are sent to the brain. And if this input is not symmetrical, if one side is stronger than the other, if one side is damaged and it's weaker, you get hypofunction. And because of this asymmetrical input, our cerebral cortex perceives that as vertigo because of this difference in the signals which our brain receives. So that is why we have vertigo. Okay. So what are the features of a vestibular disorder? Very, very simply put, we can divide the signs and symptoms into two each. Symptoms, when there's a sort of a difference in the vestibular input, one, we get vertigo, okay, because the body, the cerebral cortex perceives that the body is not in its proper orientation in space. So we perceive it as vertigo, which is sometimes also said to be a hallucination of movement, which means we perceive some kind of movement, although there isn't such a movement. So it can be described as rotational or translational types of movements. And usually there's nausea or vomiting because of the cerebellar pathways which are involved. The patient will usually complain of vomiting during the initial episode and some degree of nausea after that. So what are the signs we look for? So during an acute phase, we want to assess the vestibular ocular reflex, and one of the key signs that we look for is nystagmus. And of course, the other thing is imbalance because the vestibular spinal reflex is affected. So this is the basis of all our clinical examination steps. So to come to a diagnosis, it is like a jigsaw puzzle. We need to have good history, which is the real foundation of establishing our diagnosis, proper examination, followed by appropriate investigations. And one of the key factors that we look for in our examination is the eye findings, okay? One of which is nystagmus. Okay. So dizziness is a very, very broad term. I think the first thing we need to do when we are faced with a patient who complains of dizziness, or in our local context, patients will come to us saying, saya pening, okay? So pening can mean many things, and we need to ascertain exactly what the patient is complaining of. Is pening headache? Is pening dizziness? Okay. So the first thing is to try to get the patient to describe exactly what they are experiencing. Is it a blackout kind of sensation or syncopal attack? Is it a spinning sensation of vertigo? Okay. Is it a sense of imbalance? And finally, is it lightheadedness? So elicit exactly what the patient is experiencing. Step number 2 is to identify the likely cause. Is it something central, or is it a medical problem? So if it's imbalance, lightheadedness, syncopal kind of attacks, then it points more towards a medical cause. Whereas if the patient complains of some funny spinning kind of sensation or rotatory or movements kind of issues, then we are thinking of a vestibular disorder, especially if there's nausea and vomiting. And then the next aim is to decide whether this is something central or peripheral. Peripheral, we are looking at ENT related conditions, whereas central is more neurological type of conditions. So the following step is to move to fine tune the symptoms. Does the patient have ear symptoms, tinnitus, hearing loss? Is it positional or episodic? So if symptoms like this seem to suggest more ENT cause. Whereas if the patient has neurological symptoms, visual disturbances, weakness, numbness, some altered speech, difficulty swallowing, headache, if it's persistent, this perhaps suggests more of a central or neurologic cause. So next we go to the examination. Once you've done a proper and thorough history taking, the next step is examination. So examination, again, can be divided into several components. Patients do not come to us as an ENT or as a neurologic patient. They just come to us as a patient, and we need to examine this patient thoroughly step by step. And it's very important for us to do a general examination, an ENT examination, and then followed by a neurotologic examination and neurological examination. Okay. And physical or clinical examination has become so important that in this paper, which has been published and widely quoted, it talks about HINS. HINS is a 3-step examination of patients which looks to try and identify whether a patient has acute stroke or a vestibular problem. In fact, in this paper, they found that a 3-step bedside oculomotor examination, which is the HINS test, head impulse, nystagmus, test of skew deviation, it appears to be more sensitive for stroke than early MRI. Okay, so this paper actually advocates the importance of clinical examination. So it is important for us to be able to try and pick up findings early using just clinical examination. And clinical examination or clinical acumen, a lot of it depends on practice. So while this paper may suggest very high rates of being able to detect acute stroke, but mind you, it involves a lot of practice, and the clinician performing this test must be familiar with the test and must have really practiced the numbers to be able to achieve these rates. If not, a person or a clinician who rarely performs this maneuver is going to find it difficult to pick up the signs and it's not going to be as sensitive as an MRI. Okay. So general examination, things like blood pressure, pulse rate, these are things we need to look for. Is the patient febrile? We look at the eyes, look for pallor, signs of anemia, and we look for postural hypotension. So these are some common general conditions that can give rise to a patient experiencing a sense of dizziness or lightheadedness. Okay, ENT examination. Okay, ENT examination is not just for ENT surgeons; it's for any doctor managing or looking into patients with dizziness or vertigo. We want to look for basically middle ear disease or deafness. And how do we do that? We do 2 simple tests. One is we perform an otoscopy, that is, we put an otoscope into the patient's external ear canal and we look for findings of middle ear disease. And then we perform tuning fork test, which will give us a rough idea whether the patient has conductive or sensory neural hearing loss. Otoscopy. So it is very important to conduct this examination properly. It's important to gently pull the ear upward and backward. Insert the speculum slowly, not to cause any pain to the patient. And finally, inspect all 4 quadrants of the eardrum. So I'm going to show you a video. And many of these videos that I will subsequently show in this presentation is from a book published by or written by Professor Prabhakaran and myself. And if any of you all are interested in obtaining a copy of that, please contact the organizing team. So that's how an otoscopy is performed. Okay. And we hope to find a normal eardrum. Okay. So why is it important to look at all 4 quadrants? You know, on a simple inspection, this may appear to be a normal otoscopy with an intact eardrum. But if we were to carefully look in the attic region, there is actually an attic cholesteatoma. So things like this can be missed if an otoscopy is not performed correctly. Okay. So what are the things we look for? We look for evidence of middle ear disease. So the first picture shows an acute otitis media. The second one shows cholesteatoma. The third shows chronic suppurative otitis media. So these are all middle ear diseases, and it could give rise to infection which spreads to the inner ear, causing labyrinthitis. And sometimes in a patient with a chronic perforation, the use of ototoxic ear drops can also cause vestibular damage. So that is important to remember. Tuning fork test, we have the Rinnes and Weber's test. Again, it is important to perform this test and to perform it correctly. So here again is another video showing how the Weber's test and the Rinnes test is done. It is important to use the appropriate frequency tuning fork, and what we use is a 512 Hertz tuning fork. Okay, so we ask the patient which side he hears louder, and then we do the Rinnes test. We ask him whether he hears louder when the Tuning is in front or at the back. So if it's conductive deafness, it may suggest middle ear disease, things like we have mentioned before, otitis media or cholesteatoma. If there's evidence of sensory neural deafness, it may indicate the inner ear pathology like Meniere's disease or labyrinthitis, or even a cerebellopontine angle tumor like an acoustic neuroma. So neurotologic examination is what is new to many of us. Okay, it is not new, it has been around for some time, but these are the tests that help us to actually diagnose a vestibular condition and to separate a central from a peripheral vestibular condition. So there are 4 steps for tests that we do. These are the spontaneous nystagmus tests, oculomotor tests, vestibular tests, and cerebellar tests. Okay, so the principle again is to assess these two primary reflexes involved in balance associated with the vestibular system, which is the vestibular ocular reflex, which helps to keep our eye focused when the body is in motion, and the vestibular spinal reflex, which helps us maintain posture and prevent falls. So basically, we're looking for assessing for nystagmus and balance. So the first test is the test for spontaneous nystagmus. So how is this test done? So it's very simple. Ask the patient to keep their head still facing forward, and you place an object in front of them and ask them to look at the object, usually a pen, move it to the patient's left and to the patient's right, okay? Not more than 30 degrees because you may sometimes get physiological endpoint nystagmus, and you look for nystagmus. So this is one of the videos from our book. And that is Professor Prabhakaran. And he is explaining how the test is done. So he's holding an otoscope, the light on. So the patient looks at the light of the otoscope, the head held still. And while this test is done, we look at the patient's eyes, looking for any abnormal eye movements. Okay. So now, if the patient has a biphasic nystagmus, this suggests a peripheral vestibular disorder. So what is a biphasic nystagmus? Biphasic means it has a fast component and a slow component. So the eye beats quickly to one side and slowly moves back to its original position. So it's biphasic. So a horizontal biphasic nystagmus is usually associated with a peripheral vestibular disorder. And this is a video demonstrating that. And in a peripheral vestibular disorder, the fast phase of the nystagmus beats away from the site of the lesion. So in this patient, when he looks to the left, there is nystagmus to the left. So the site of the lesion is on the right. So the fast phase of the nystagmus beats away from the site of the lesion. So now this is another type of nystagmus, and this is a pendular nystagmus. So a pendular nystagmus means the eye moves to the left and to the right with equal intensity, just like a pendulum of a clock. Okay, so there's no fast phase or slow phase. Both phases are similar in intensity. So this signifies either a congenital or a central vestibular problem. So remember, if there's nystagmus, which is of acute peripheral vestibular origin, it is only one direction. It's horizontal. Okay, horizontal. Okay, so the diminished vestibular function on the site of the lesion leads to fast phase of nystagmus away from the site of the lesion. Meaning, if there's a left-sided lesion, the fast phase is to the right. Okay, and it moves together. So conjugate means both sides move together. Disconjugate means it doesn't move together. So in a peripheral vestibular disorder, the nystagmus will be conjugate, will be moving together. If you get a disconjugate kind of movement, it is not a peripheral vestibular disorder. It's either a central or some medical or neurological problem. And finally, of course, it obeys Alexander's law. Okay, so this is another video demonstrating a peripheral vestibular disorder with a horizontal nystagmus. So this is what we will see. So this patient has a biphasic nystagmus, and the fast phase is to the patient's left. So which is the side of the lesion? The side of the lesion will be on the patient's right. Okay, so you get a fast beating phase towards the left. So it's horizontal. Both the eye movements are together. It's conjugate and it's biphasic. So these are features of a peripheral vestibular disorder. Okay. Now, if we get something like this, if you see something like this in a patient, here we see it's a vertical nystagmus. It beats from up to down. So the moment you see a patient with a vertical nystagmus, this is not a peripheral disorder. It usually signifies a central problem. The next is gaze evoked. Gaze evoked means when the patient gazes to the right, it beats to the right. When the patient gazes to the left, the nystagmus beats to the left. So it is like a direction changing nystagmus. So once again, when you have a direction changing nystagmus, this signifies a central lesion. Okay, this is another video which I'm going to show you. So looking at this, what can you tell me about this patient? See, when the patient looks to the left, there's no nystagmus. When he looks to the right, there is a right beating nystagmus. So he has got a horizontal right beating nystagmus, which is stronger when he looks towards the right. So he has got a features of a peripheral vestibular lesion on the left side. So this patient actually had surgery, and this is an iatrogenic injury, which and post-operatively you notice the horizontal nystagmus towards the right. Okay, let's say we have a patient presenting with nystagmus like this. Is it vertical? Is it horizontal? It's vertical and it is gaze evoked. Okay, when the patient looks to the left, there's nystagmus, downbeating nystagmus. The patient looks to the right, there's vertical downbeating nystagmus. So again, this signifies a central pathology. Oculomotor examination. So these again are tests which check or look at the movement of the eye. And there are 4 tests that we do. Fixation, okay, looking at the ability to the eye to fixate on a particular object. Smooth pursuit is the ability of the eye to track the movement of the object, an object, and whether there is saccadic, that means quick nystagmic kind of movements, and the ability of the patient to converge and diverge eye movements. So all these tests should be normal in a patient without any vestibular disorders. If it is abnormal, it signifies a central vestibular problem. Okay. So again, this is a video demonstrating the eye examination. So the patient is asked to fixate his eyes on the object. So if he's unable to fixate, it signifies a central disorder. Then he's asked to track the movement of the object. If it's unable to track the object smoothly, if there's sort of a shaky movement, then it signifies a central pathology. So here again, the patient is assessed for movement, eye movement, for smooth eye movement. And finally, a test of convergence and divergence is done. So all this should be normal in a patient with who does not have any central or peripheral vestibular disorder. So if any abnormality will signify a central vestibular disorder. Okay. So here's a video showing a smooth pursuit deficit. So we look at the patient's eyes. Patient is asked to fix on an object. And as the patient looks towards the right, there's jerky movements. So this is abnormal smooth pursuit. Okay. So a jerky movement like that signifies an abnormal smooth pursuit and probably a central pathology. So then we come to specific vestibular tests, which is the Halmagyi Maneuver, the head shake nystagmus, and Oscillopsia testing. So the Halmagyi is also known as the high frequency head thrust or the head impulse test. Okay. So of course, now we have instruments that will help us do this test, but it's good to know how to do this test clinically. So the examiner faces the subject or the patient, and the head is quickly moved in one direction when the patient fixes his gaze on a certain point. So in this case, the patient is able to fix his gaze on the specific target. If there is any abnormality, then there will be a sudden lag in movement and we will notice a corrective saccade. Okay. So corrective saccade signifies pathology in the ear where the head is thrust towards. So if a patient's head is quickly thrust to the right, and then there's a corrective saccade, so it is the right ear which is diseased. So now his head is thrust to the left, then from the right, and then to the left. So you notice the saccade when the head is thrust to the left. So when he looks to the left, there's a slight delay. Okay, there's a saccade, there's a corrective saccade. So it indicates the left ear has some vestibular deficit or hypofunction. So as you can see, it is not an easy test to do, and it requires a lot of practice to be able to be skilled in this maneuver. Next is a head shake nystagmus. So the principle is similar to Halmagyi maneuver, but in this case, we put Frenzel's glasses onto the patient, and the patient's head is shaken quickly at least 20 times. So both vestibular systems are tested. And after shaking the head many times, if there is a difference in input, if one side is weaker, then there will be nystagmus towards the other side. So finally, the patient is asked to open his eyes, and if there's any imbalance, we will be able to pick up nystagmus.
Rapidly back and forth.
So here we see head shake nystagmus in a patient with pathology. So the head is strictly shaken, and we see a right beating nystagmus. Okay, so this suggests a left-sided lesion. Finally, the last test is Oscillopsia testing, which actually looks for bilateral vestibular deficits, and a simple test can be done using a Snellen chart. So the patient is asked to look at a Snellen chart and is asked to read the lines without the head shaking and with the head shaking. And usually what will happen when a patient has bilateral vestibular deficit, he will not be able to read the lines because he sees everything moving and is not able to focus both his eyes on the Snellen chart. So in this case, the patient is asked to read the Snellen chart. So his head is shaken. Okay. And if he misses more than 3 lines, it signifies a bilateral vestibular loss. So this is how a patient with oscillopsia will perceive their environment. Okay? They feel everything is moving because their VOR is not functioning properly, both their VORs. And so whenever they move, they also see their surroundings moving. Okay. So that is oscillopsia. And then we move to cerebellar tests. Okay, cerebellar tests, of course, if these tests are positive, they signify a central vestibular disorder. So one of the simplest tests that we do is to look for coordination. So if there's incoordination, it suggests a vestibular deficit. So then we look for pass pointing. Okay. So basically, we look for incoordination. So if the patient's movement is incoordinated and the patient cannot sort of touch the point in a smooth manner, it suggests a cerebellar deficit. So there are a few tests which can be done to check this the smoothness of movement or this coordination of movement. And if there's any abnormality, it signifies a central disorder or cerebellar disorder. Then we also do the Rombergs and Gait. Okay, again, if any of these tests are abnormal, it suggests a central problem or a cerebellar problem. So that's a tandem gait. Okay, so it's a more difficult than a normal gait, and if a patient has difficulty doing this, it may suggest a central disorder. Okay, so this subject has normal Rombergs and Gaits. Okay, so if you have an abnormal Rombergs, the patient will tend to fall towards the side of the lesion. Okay, and again, during the Gait test, if the subject tends to veer towards the side of a lesion if there is a vestibular deficit. Okay, and finally, of course, the most important test, I think, for most of us is to do a Dix Hallpike test. So this is a simple test which can be done in any clinic or outpatient setting. And we want to look for rotatory nystagmus, which is classical of benign paroxysmal positional vertigo. So this is a patient with a positive BPPV test. So we see this classical rotatory nystagmus beating towards the side of the ear tested. And it stops after a few seconds, okay, which is classical BPPV, benign paroxysmal positional vertigo. And with that, I'd like to thank you very much for your attention. And many of these things, most of these things which I've explained will be gone through in much more detail by some of the other esteemed speakers. And I hope this gives you a broad overview of vestibular disorders and some of the eye findings and tests and clinical steps that we do to try and identify or diagnose a vestibular disorder. That I'd like to thank you very much and thank the organizing committee once again for this invitation. Thank you.